In my neurology clinic, I sit across from patients who are convinced they are losing their minds. They come in frightened. They come in with their adult children beside them, and they say the same thing. I think I have Alzheimer's. And often, they are wrong. What is actually happening is quieter than a diagnosis. It is slower, and it is sitting in their medicine cabinet. The medications I am going to walk you through today are not rare. They are not obscure. They are pills sold right next to the vitamins. Sleep aids like Benadryl, bladder pills, common anxiety medications, heartburn drugs. Prescribed at routine checkups, picked up at every pharmacy in the country. The brain does not send an alarm when these drugs start doing damage. The changes are gradual. A little fog, a little word-finding trouble, a little less sharp than you used to be. By the end of this video, you will know exactly which of these carry the highest neurological risk, why they cause harm at the biological level, and what to do about it. Before we get to the specific drugs, you need to understand something important about the aging brain, because it changes everything about why these medications hit harder in your 60s and 70s than they did in your 40s. Think of your brain at 65 as a slightly older electrical system. The wiring still works, but the insulation on some of the wires has thinned. The signals take a fraction longer, and the whole system has a little less tolerance for disruption. 3 things change as we age that make the brain more exposed to medication harm. First, the brain produces less acetylcholine. That is the chemical messenger your hippocampus depends on to encode new memories, to take what just happened and file it away. Think of it like a broadcast signal going through a microphone. When acetylcholine is strong, the signal is clear. When levels fall, the broadcast weakens and the message starts to break up. Less acetylcholine means the memory system is already running leaner than it used to, which matters enormously when a drug comes along and clamps down on that signal entirely. Second, the blood-brain barrier becomes more permeable. That barrier is your brain's security system. It controls what gets in from the bloodstream. As we age, it becomes a little more porous. Drugs that once stayed outside start crossing in. Third, the liver and kidneys slow down. Medications that a 40-year-old body clears in a few hours can linger in a 70-year-old system for much longer. So the dose on the label is not really the dose your brain is experiencing. Now add polypharmacy to that picture. Polypharmacy simply means taking 5 or more medications at the same time, and in seniors over 65, that is extremely common. When you layer multiple drugs on top of each other, the brain becomes a target, not just the condition you are trying to treat. Here is how I explain it to patients. Imagine an electrical cord pulled slightly out of the wall. The lamp flickers. That is one medication crossing into the brain. Now pull it out a little more, and a little more. 3 or 4 drugs doing the same thing simultaneously, and the whole room starts to go dim. That dimming has a name. It is called anticholinergic burden. And it starts with a drug most people assume has nothing to do with the brain at all. One that is sitting in millions of medicine cabinets right now, marketed as completely harmless. So let's start with the drugs that require no prescription at all. You can walk into any pharmacy, pick them up off the shelf, and bring them home. They are marketed as gentle, familiar, safe. And that is exactly what makes them so easy to overlook. The first one I want you to know about is diphenhydramine. You probably know it better by its brand names, Benadryl, ZQuil, the PM in Tylenol PM or Advil PM. It is the most widely used over-the-counter sleep aid among seniors. and it is one of the strongest anticholinergic drugs available without a prescription. Diphenhydramine works by blocking that acetylcholine signal directly, the same one we just talked about, the one your hippocampus depends on. In the short term, that produces drowsiness. But when you are taking this drug night after night, week after week, you are repeatedly silencing the very system your brain uses to form and retain memories. I sat across from a patient not long ago, a sharp, articulate woman in her early 70s, whose family had brought her in because she was struggling to find words, forgetting appointments, feeling foggy by midday. They were frightened it was the beginning of Alzheimer's. When I went through her medications, I found she had been taking a PM pain reliever every single night for nearly 2 years. Once we identified what was happening and worked with her physician to address it, the fog began to lift. That story is not unusual. In my neurology clinic, I see versions of it regularly. Large studies tracking tens of thousands of seniors have found that regular use of strong anticholinergic drugs for as little as 60 to 90 days is associated with measurable changes in cognitive function. And I will tell you shortly about a prescription drug, one considered completely routine, dispensed every day for a very ordinary problem, that carries an even stronger association with dementia than diphenhydramine does. Most patients are never warned about it at all. The risk compounds the longer the use continues and the higher the cumulative burden. Now, diphenhydramine is not alone in this category. First-generation antihistamines, drugs like chlorpheniramine, which shows up in many cold and allergy formulas, and hydroxyzine, which is sometimes prescribed for anxiety or itching, carry the exact same anticholinergic mechanism. They feel mild, they are old and familiar, but they are doing the same thing inside the brain. The reason this matters so much is not because any single dose is catastrophic. It is because these drugs feel harmless, so people take them for months or years without ever questioning whether they are safe for long-term use in an aging brain. Here is what I tell patients. If you need an antihistamine for allergies, second-generation options like cetirizine or loratadine, Zyrtec and Claritin, do not cross the blood-brain barrier in any meaningful amount. They are a straightforward, safer swap. For sleep, the picture is a little more nuanced, and your doctor needs to be part of that conversation. There are evidence-supported options. Low-dose doxepin at 3 to 6 milligrams, Rameltion, that work through completely different mechanisms and do not carry this anticholinergic risk. Cognitive behavioral therapy for insomnia, what clinicians call CBTI, is the gold standard approach and has no neurological side effects at all. The danger with these over-the-counter drugs is not dramatic. There is no sudden event, no obvious turning point. It is slow, quiet, and easy to attribute to age. But this is not just aging, it is biology. And biology can sometimes be addressed. Now, what I just described is concerning. But the prescription drugs in the next category carry an even heavier load, and they are far harder to stop. Let me tell you about a drug class that surprises almost every patient I discuss it with. Not because it is obscure, because it is prescribed so routinely, so confidently, that most people never think to question it. Bladder antimuscarinics. Drugs like oxybutynin and tolterodine prescribed to treat overactive bladder, the urgency, the frequency, the loss of control that affects so many people over 65. These are among the most commonly prescribed medications in older adults. And the research is clear that they carry some of the strongest associations with cognitive decline of any drug class we have. Here is why. These drugs work by blocking muscarinic receptors in the bladder wall. That reduces the spasms. That reduces the urgency. So far, so good. The problem is that muscarinic receptors are not only in the bladder. They are densely packed in the hippocampus, the brain's memory center. And the drug does not know the difference between a bladder wall and a brain cell. It blocks both. Oxybutynin specifically has among the highest anticholinergic potency of any commonly prescribed medication. We are not talking about a small signal here. Large studies have found bladder antimuscarinics carry some of the strongest dementia associations recorded across all anticholinergic drug classes. I had a patient whose family brought her in concerned about what they described as rapid cognitive decline. She had become confused, withdrawn, slower in conversation. She had been on oxybutynin for 3 years. Within weeks of working with her physician to transition to a different approach, her clarity began to return. Her family called it remarkable. From a neurological standpoint, it made complete sense. If you or someone you love is on oxybutynin or tolterodine, this is a conversation worth having with a doctor. A drug called mirabegron treats overactive bladder through a completely different mechanism. It does not cross into the brain. Pelvic floor physical therapy is also highly effective, with 0 cognitive side effects. Now let's talk about a category that is harder to navigate, because it involves a drug many people genuinely depend on. Benzodiazepines. Xanax, Valium, Ativan, Klonopin. Prescribed for anxiety, for insomnia, sometimes for muscle tension or nerve-related pain. Often started as a short-term solution and quietly continued for months or years without anyone stopping to reassess. These drugs work by enhancing GABA, your brain's primary braking signal. In the short term, that quiets anxiety, and it can be a genuine relief. The problem with long-term use is that chronically applying that brake slows down the overall speed at which neurons fire and communicate with each other. Studies consistently show measurable impairment in processing speed in long-term benzodiazepine users. Reaction time slows. Thinking becomes less fluid. The brain, quite simply, runs at a lower gear. I want to be honest with you about the nuance here. The direct link between benzodiazepines and dementia is less definitive than what we see with anticholinergics. The research points in that direction, but the picture is more complex. What is not complex is this: the documented risk of falls, delirium, acute confusion, and measurable cognitive slowing in older adults on long-term benzodiazepines is significant and well established. And here is the critical point. If you are currently taking a benzodiazepine, do not stop on your own. I want to be very direct about that. Benzodiazepine withdrawal can be dangerous. This requires a slow, supervised taper with a physician who knows your full history. There is one more drug in this category I want to mention, because most patients are never warned about it. Tricyclic antidepressants used off-label. Drugs like amitriptyline, sometimes prescribed for nerve pain, migraines, or sleep at doses below what would be used for depression. These carry a very high anticholinergic burden. They often feel innocuous because the dose is low and they were prescribed for something other than mood. But from the brain's perspective, that distinction does not matter. The acetylcholine blockade is real, regardless of why the prescription was written. If you are on amitriptyline for nerve pain or sleep, ask your prescribing doctor whether a lower anticholinergic alternative exists for your specific situation. There are often options. Now, what I have described so far all shares one mechanism: the blocking of acetylcholine. But the next category works through an entirely different pathway. It does not touch acetylcholine at all. Instead, it quietly steals something your brain depends on to keep its wiring intact. And most people taking these medications have no idea it is happening. I want to be careful with how I present this next category, because the evidence here is different. These drugs are not anticholinergics. They do not block acetylcholine. And for many seniors, they are genuinely important medications that should not be stopped. But there are real biological mechanisms worth understanding, and your doctor may never bring them up. The first is proton pump inhibitors. Omeprazole, pantoprazole, esomeprazole, sold under names like Prilosec, Protonix, and Nexium. Prescribed for acid reflux, heartburn, and stomach ulcers, taken by millions of seniors, often for years, sometimes indefinitely. Here is the pathway that concerns me. These drugs reduce stomach acid, that is the point. But stomach acid is also required to absorb vitamin B12 from the food you eat. B12 is essential for maintaining myelin, the insulating sheath that wraps around your nerve fibers and keeps signals moving cleanly and quickly. Think of it like the coating on an electrical wire. When B12 levels fall, that coating starts to fray. Signals become slower, less reliable. Over time, that shows up as fatigue, cognitive fog, and in more significant deficiencies, real neurological symptoms. This is an indirect pathway. The PPI is not attacking your brain directly, but it is quietly setting off a chain of events that can get there. The practical step here is simple. If you have been on a proton pump inhibitor for more than a year, ask your doctor to check your B12 level. A blood test. Supplementation, if needed, is straightforward and inexpensive. This is one of the most actionable things in this entire video. Now, statins. This is the most nuanced entry on this list, and I want to be precise. Statins overall actually show a protective signal against vascular dementia. For most seniors with meaningful cardiovascular risk, the brain protective benefits of keeping vascular disease in check outweigh other concerns. I am not here to tell you to stop your statin. What I will tell you is this. A subset of patients on fat-soluble statins, simvastatin and lovastatin specifically, report a reversible cognitive fog. Studies show that when these patients switched medications or stopped, the fog lifted. The effect appears to be real in some individuals, even if it is not universal. Hydrophilic statins like pravastatin and rosuvastatin penetrate the brain at much lower levels. If you are on a lipophilic statin and you have noticed changes in your thinking, that is a specific, targeted conversation to have with your cardiologist. Not a reason to stop, a reason to ask whether a different statin might serve you just as well. So here is what I want you to do right now, before anything else. Before your next doctor's appointment, gather every medication you take. Prescription bottles, over-the-counter boxes, supplements, everything. Bring them in a bag. Then ask 3 questions. Is this medication still necessary? Is there a lower anticholinergic alternative? Has anyone reviewed all of my medications together recently? Those 3 questions have changed outcomes for patients I have sat across from. The fog they thought was permanent turned out to be reversible. That possibility is worth one conversation with your doctor. But here is what I need you to understand before you go. Addressing your medications is a real and important step, but it is only one part of the picture. What I see in my clinic consistently is that even patients who get their prescriptions right continue to struggle because of what they are doing in the first few hours of every morning without realizing it. There are daily habits, things most people consider completely harmless or even healthy, that actively work against the neurological progress you are trying to make. And if those habits stay in place, the work you are doing on the medication side gets quietly undermined day after day. The next video on your screen right now addresses exactly that. It is the piece that completes this. I would not send you there if I did not think it mattered, but in my clinical experience, it is often what makes the difference between someone who improves and someone who wonders why they are still struggling. Your brain is remarkably resilient. Do not leave it without the full picture. I will see you in the next one.